Hello, and thank you for joining us for today's virtual Dean's Notebook event featuring Hopkins School of Nursing Dean Sarah Szanton. This event is in partnership with the Johns Hopkins Office of Government, Community and Economic Partnerships as a part of their annual showcase series, which highlights Hopkins programs with strong relationships with Baltimore City and the state of Maryland. I'm Danielle McRae. I'm a lifelong Baltimorean and a Baltimore City Councilwoman for the 2nd District, representing Northeast Baltimore and parts of Southeast Baltimore. And that would include communities like Frankfurt and Sedonia. And as chair of the city's Health, Environment and Technology Committee and chair of the Suicide Prevention Legislative Group, I'm deeply committed to tackling pressing issues facing our communities. Today, I'm honored to be a part of this conversation about the Neighborhood Nursing Program, an initiative that not only addresses health disparities, but also meets people where they are, bringing essential health services directly into our neighborhoods. From home visits to senior centers, this program is a powerful step toward closing the health equity gap in Baltimore City. This innovative, collaborative program connects local community organizations to the schools of nursing at Johns Hopkins, the University of Maryland, Morgan State University, and Coppin State University by going door to door to deliver healthcare to communities that are facing ongoing structural barriers and access to care. And as Dean of the Johns Hopkins School of Nursing, Sarah Szanton, who is with us, has led the efforts to provide these neighborhoods early and consistent access to nurses and community health workers with the goal of decreasing infant mortality and premature death rates, increasing vaccination rates, reducing depression and anxiety, and improving other important indicators of health and well-being. My journey in public service started early, growing up in a family that believed in hard work and civic engagement, whether it was helping my mom with the neighborhood community association or co-founding a political club to energize local leadership. I've always believed in the power of community-led action. It's this belief that guides my work today, and it's why I'm so excited to be here to speak about neighborhood nursing and also learn more. Joining Hopkins in 2021 as a 15 of the School of Nursing, Sarah Szanton holds a joint appointment in the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health and the Johns Hopkins School of Medicine. Under Dr. Szanton's leadership, the Johns Hopkins School of Nursing is ranked #1 nationally by U.S. News and World Report for its Master's and Doctor of Nursing practice programs, and #3 globally by QS World University. Since joining the school, she has helped shape the pioneering pathway to PhD nursing scholars program, established the term professorship for rising faculty, launched the impactful policy honors program, and is chartering the creation of an innovative policy institute to advance health policy leadership and research for global nurse leaders and scientists. As a researcher, Dr. Szanton has published more than 200 papers and been principal investigator on more than 20 million in grants from the National Institutes of Health, the Center for Medicare and Medicare Services Innovation Center, the Robert Wood Johnson Foundation, and has been elected as a member of the National Academy of Medicine. Just at this point, I'd like to remind those just tuning in live to please use the chat feature below to leave comments and ask questions. We'll be monitoring the conversation, and we'll do our best to respond to as many questions as we can during the Q&A towards the end of the broadcast. And now, without further ado, I am thrilled to turn it over to Dean Szanton to learn more about this incredible program.
Thank you. Thank you for that very kind introduction. It's an honor to be with you on this stage. And thank you to everyone who's joining. So I'd like you to imagine a future for Baltimore and the whole country where everyone can participate in society because they're healthy. And in this future, people have enough food, live in safe homes, breathe clean air, and drink pure water, and their communities are strong. And I think as healthcare providers, we often don't think about that future. We think about just the reacting to the problem that somebody has in front of us. Someone's in pain, or they're hungry, or they're hurt in some way, or they they need some help. But if we work together on a vision where everyone is healthy and strong, I think we're at a tipping point in this country. And so let me tell you about that. In Maryland, we've had a history since the 1980s of the insurers working together through a cost commission that sets rates for the hospitals, and then hospitalizations are paid for. And we see now, as the time since the 1980s, for all those insurers to work together to change the population's health. So what we've done, as Councilwoman McRae said, is together with Morgan State and Coppin State and University of Maryland, we've set up a program called Neighborhood Nursing. It's a nurse and a community health worker. And the vision, we're not to the vision yet. The vision is to every doorstep: laundromats, libraries, schools, jails, streets, seniors who are homebound, everywhere would have access to a nurse and a community health worker over time, a longitudinal relationship. And, it's just common sense, right? You can tell that would be useful. And I'll tell you some stories as we go about some of the impact we're already having. We started last fall, just listening. And Councilwoman McRae talked about community-inspired action and working with communities. So we are not just showing up and saying, this is what we're doing. We've just been listening and listening. And I used to provide house calls as a nurse practitioner in West Baltimore on behalf of Bon Secours. And so I'm really used to knocking on people's doors. But the first neighborhood we've started in is Johnson Square. And many members there respectfully said, please don't knock on our doors. We don't trust you yet. And so we said, okay, what should we do? And they said, come to the places we trust and we'll come to you. So we've been in senior centers, in laundromats, in the parks, and we've set up pop-up clinics. But before we get into the specifics, which I'd love to tell you about, I want to frame this more broadly, that the US spends more than double of any other Western country per person on healthcare or medical care, really reactive care. And we have the worst health outcomes of any. So you could imagine if we spent that much, we should all be really healthy, or we should be spending a lot less for the amount of help that we're getting. But we have this terrible mismatch. And for years, 30 years, health economists, health policy people, Congress people have been saying this. And we haven't done anything that's big enough to change it. The Affordable Care Act was really important to get people covered. And there's a lot of things that the governments on all the levels are working to do this. But if you look at the other countries, they're doing a better job of prevention and longitudinal care, and a better job with high blood pressure and obesity and diabetes and some of the chronic illnesses. Those countries are like Costa Rica, where they treat people in a geography. And in a certain geography, you have a nurse, a community health, it differs different places, but where everyone on the same block would know who they see. And as an example, I love this example, in Amsterdam, the midwife has a parking place in each neighborhood, and you just leave it open because the midwife is going to be coming, and she or he knows that they're always there and that they have that access to that geography. And people who give birth in that neighborhood know who their midwife is. We're never going to change the fact that in this country, insurance is employer-based. And so there's a real patchwork. We have a very different situation than other healthcare countries. But that doesn't mean we can't get them to work together for geography. So on a certain block, you may have people covered by Blue Cross or Medicaid or Medicare or Humana, but you could have a nurse and a community health worker paid for by funds from those who could geographically see people. And regular care, we know, saves $736 per person annually. And we will be able to save more than that by having this neighborhood nursing model. So I know we're going to get into questions, but I just want to tell you a little bit about what we've done so far. So I mentioned that we're doing this with Morgan and Coppin and University of Maryland. The actual being in Johnson Square and started in January after a lot of listening, as I mentioned. And I mentioned it's a nurse and a community health worker. And some listeners or watchers may have interest in why those two, and why not just community health workers, for example, or why not just nurses. So I want to tell you a little bit about what they do. But Councilman McRae, feel free to interrupt at any point, but I'll just keep on going for now. We'll save questions. So the nurses set up blood pressure screenings, first aid crisis response, skin and wound care, medication management. There's a lot of people, maybe including some people watching, who don't necessarily know what they're on or why they're on it, or if it conflicts with other things. Health behavior screening for substance use disorder, and referral for that. Insurance benefit assistance, care coordination, voter registration, referrals to food resources, referrals to in-home supports, and transportation to appointments. And just as one example, that was a long list. As one example, we set up blood pressure screenings. Very simple, right? And someone doesn't have to already be decided they want to work with you just to get their blood pressure screened. And if the first 200 people that we checked their blood pressure for them, 89% were elevated. So only 11% were in what we would consider a healthy blood pressure. The other 89% had high or very high blood pressure. And we had a few people who we had to get into care right that moment. If you think about blood pressure, our blood is all in our bodies. And if the blood pressure is high, it affects our vision. It affects, we're much more likely to get dementia. We're much more likely to have kidney failure and heart failure. And so if you can, and that's just one community, but if you multiply even just that one thing, not talking about childbirth or vaccination, just blood pressure, if you could imagine that all across Maryland, people would know if they have high blood pressure, and there's a nurse right there to help them with access. And we had the good fortune of Senator Bernie Sanders came to visit neighborhood nursing, and he sat right with an older gentleman who said, I have high blood pressure, I have Medicare, I have a doctor, and I don't go. I come to these nurses because they're here and I trust them. And those two things are really important. Nurses are the most trusted health profession. And to be in where people live, to meet them, to see them over and over when they walk by, to be counted on, is really crucial to neighborhood nursing. The other aspect of being where people live is about trust and about changing the power dynamics. If you get dressed up and you go into a hospital or a clinic setting, usually the clinician's in charge. They don't see you in your context. They don't see your family photos, what matters to you. And the power is different. Clinicians are much more likely to talk over patients if they're in a clinical setting. Out in the world, where really health is, right, is where we live our lives. The power dynamics are much more equivalent. So besides the kind of the list of what I said, unfortunately, the nurse has already, just since January, found 4 people who were unresponsive, who she provided direct life-saving care and initiated 911, and those people survived. We had a 5-year-old last week who was living with her grandmother because her parents left their housing, and she needed vaccinations and dental care and a well child visit. And in fact, she hadn't been allowed to enroll in kindergarten yet because she was not up to date on her vaccine. So she was missing school time. And the community health worker helped get her medical insurance information, and the nurse connected her with a pediatrician at East Baltimore Medical Center. And in 3 days, she got her well child visit, her vaccinations, and she started school 6 days later. So that's the great, and that's one tiny story. We have so many stories. And in fact, her grandmother, we checked her heart rate, and it was so low that she had to get admitted to the hospital. She had heart issues. They fixed the problem, and she's back being able to take care of her granddaughter. So, you multiply these over and over and over, and you can just see it's common sense that something like this would work. And where I'm sure people are getting questions in their head is, well, how would you pay for this? It sounds nice. Yeah, of course, it'd be nice to have a nurse for every block. And I want to talk about the community health worker as well a little bit more. But when we'll get to the payment. So on the community health worker, community health workers are incredibly wonderful people and great at all kinds of health-related skills that are really important. So in that example, I talked about getting her medical insurance information. We were lucky enough to have a PBS NewsHour piece on neighborhood nursing, and Terry, the community health worker who I hope is with us today, talked about that a patient had lost his wallet. And because of that, he lost it 3 years ago. And because of that, he hadn't had medical care since then. He was 78. But he didn't have his Medicare card or his driver's license. And Terry helped him get those back. And now he's back in medical care. Terry also works with Be More Power, which is part of Behavioral Health Systems Baltimore, with the B. Gaddy Family Center, with the City of Baltimore Medicare training, so that people can understand how to get Medicare and what's the difference between Medicare and Medicare Advantage, and also Civic Works and the Mayor's Office of Older Adults Services. So you can see, working together, a nurse and a community health worker are great partners in terms of their skills and the resources they bring to bear. And I'll just say a little bit about how to pay for it, because I'm sure there's questions, and then I'll stop and we can get to more of a dialogue. But if you think about it, insurance money is really all of our money all together. It's either taxpayer money like Medicaid or Medicare, or Medicare we've all paid into our Medicare, or it's through our employers. Like, right, we get, if you look at your pay stub, your employer pays usually some into your health insurance, and so do you. And so insurers are not some big other player, they are us. And as we think about a beautiful new system, the insurers will ultimately save money, and so will the state and the federal government, if we could roll out a program like this to everyone. And when I say everyone, I mean everyone. And we've started in neighborhoods that have fewer resources, but over time, this would be like Social Security or Medicare, where everyone gets it. We're using the term targeted universalism, which means it's targeted where some people may need more resources, but everyone gets it. And so your child, your grandmother, your dad, you would have a nurse and a community health worker in your neighborhood. So let me stop there, and I'd love to answer any questions.
You provided such great information about the program. I'm just going to start with one question myself. And you mentioned, well, you spoke about a tongue, but the one thing that centered me when you first started was that you said, hey, when we were knocking door to door, neighbors stated that we don't want you knocking on our door. And you spoke about power dynamics and mistrust. Given the history of distrust between marginalized communities such as Johnson Square and healthcare institutions, can you just expound more on how does the neighborhood nursing work to build trust and encourage participation?
Sure. So I think part of it is just showing up. We've heard that over and over again. I see you showing up. I see you keep coming back. And in fact, we just had a garbage collector on the east side say, I'm from the west side, and I want something like what you've got here on the west side. So much of trust is being consistent and being clear and being transparent. And nobody's making any money off of this. This is really just an idea that we are trying to lead with, to show what could be possible. And to me, there's been a checkered history between Johns Hopkins and East Baltimore. I think we all recognize that. As leaders of Hopkins, I think we're especially responsible to changing that power dynamics, to really deeply listening about what matters. And as I mentioned, nurses are very deeply trusted, and so are community health workers, being from the community. And if we show that that power is also in community's hands and not just what we want to do, then I think that can be really powerful. But of course, it would be really important to hear from neighbors and people we're working with about the trust, more than it's easy for me to think, oh, people should trust us.
Okay, so a neighbor in Johnson Square, because I have family there, told me that you guys started a community walking group. Tell me briefly that.
Yes. And so that is really fun because I think when I was first thinking about this, I was thinking about one-on-one visits, or maybe family visits. But the neighbors said, we would like a walking group, and said, some of us feel maybe afraid to walk by ourselves around the neighborhood, and we don't really know each other, some people said. And so we started a walking group on Tuesdays, and people have started to come out from multiple places in Johnson Square to do it. And one person told us very specifically it's helped her depression, and that she had felt kind of isolated, and having this to look forward to, and knowing she can get outside. And our listeners may not know, Johnson Square is a lovely community garden, community farm, where the vegetables are free to folks. And they've just started to bring in other kinds of food to the community garden also. And there were some people in the neighborhood who didn't know about that resource. And this part I just love. One of the members said, you know what, we don't have to wait for a nurse to do this. We've done this now. We could do it also on Thursdays when the nurse is not here. And so the walking program has grown and has created new relationships within the neighborhood. And I think that's a really good example of that you can start an idea and then communities can take it on themselves. We've also started, after the walking group, there's something the group calls a health huddle, and the community members vote on what topic they would like next. And so there's a different topic that's kind of like a group visit together. And of course, in a group visit, you wouldn't say, oh, my arm hurts or something. It's much more a topic that might be useful to everyone, like signing up for Medicare, for example.
Thanks so much for sharing that. I'm going to get to some Q&As, some questions that we have in the chat. So we're going to start with Michelle. She wants to know, how do nurses get involved in the program?
Well, great. Come join us. We are actually hiring.
Hey, Michelle.
So, I think nurses could certainly volunteer if they would like. If nurses want to work in the program, we are handing over the money that we've been getting from writing grants to Healthcare Access Maryland to implement the program with us. And so Healthcare Access Maryland was set up, but for those of us who are old timers, when Peter Bielenson was the city health commissioner. And the idea was to set up a structure that is trustworthy and is what they call quasi-governmental, meaning it can work with the government, but also as a trusted partner for others. And so, for example, they do all of the physical exams for children in the foster care system. And so they have great Medicare sign up and Medicaid, and they've got nurses and community health workers already. And so they will be the implementing partners moving forward for neighborhood nursing. While we in Morgan and Coppin and Maryland will be doing a lot of the thought leadership and writing about it and speaking about it, and they'll be the implementers. And that saves more of the grant money to do the actual work because they have lower like overhead costs and other costs to do the work than Johns Hopkins and Morgan and Coppin and Maryland do.
Okay.
Sorry, that was a long answer, but
Look, I think we got it. We're going to go to Cindy, who wants to know, have other schools of nursing medicine started looking at the program here in Baltimore as a model for other cities? I feel like nationwide folks are looking at it, but yeah, that's her question.
yeah, so I think nationwide people are, and but a lot of states don't have the same innovation structure that Maryland has, where there's a structure for insurers to work together. However, so the part of the government that makes Medicare and Medicaid policy, it's called CMS, Center for Medicare and Medicaid Services, has created a model that 4 states have applied to join. So Maryland's one of them, Vermont, Connecticut, and Hawaii. And what they've said is for those 4 states that they want to cap hospital spending and put more of it into primary care. And so we are trying to say, okay, this is a good example of what to do in primary care, because if you think about it, when you go into primary care, if primary care was only thinking about you and the others who went, that's still leaving out the people who are homebound or the people who don't know how to get there or can't get there. And so we've been arguing that real primary care is primary care for the neighborhood, for whatever is around them. And so in this, what's called the AHEAD model in those 4 states, we're trying to say, well, this would be a perfect way to grow neighborhood nursing to those 4 states. So I think that's where the initial first growth will be in terms of what we're thinking.
And just as a follow-up, how do you think a program like this would work in rural areas versus urban areas?
It's a great question, and I have a lot of experience with developing programs. I developed a program called Capable that's now in urban and rural and suburban and frontier counties. And people are people wherever they are. And as long as you're always putting the patient, the person in charge in terms of what matters to them, it is not hard to adapt a program to rural areas. It's all there is. There's more driving, of course. And if you supplement it with some phone call visits or telehealth, then it could be just as effective. In fact, in some ways more effective, because there's fewer primary care clinics in rural areas and fewer hospitals. And so a program like this is even more needed in some ways in rural areas than urban.
We have a question from Barbara. She wants to know, how do you address mental health within the community work in the
I'm
program?
so glad you asked that. So people may know that we're having a real mental health crisis in this country. And it's a combination of, our teens came out of COVID without all of their rituals and and what they usually would have gotten developmentally in high school. People left the workforce in terms of behavioral health. And if you look at the mental health needs of the country, I'm not talking about schizophrenia or bipolar or some of the more intense psychiatric conditions, but the majority of the behavioral health crisis is about anxiety and depression. And both of those are conditions that actually community health workers in other countries do very effective therapy with, and so do nurses, cognitive behavioral therapy. And so we are trying to train the nurses and the community health workers in those mental health techniques and in PTSD treatment, because we used to think that PTSD was something that people got from wars only. People used to call it shell shock or other war-related diagnoses, but PTSD can happen from other kinds of trauma, unfortunately. And so we are looking to train this workforce that we're talking about to be able to address mental health. And importantly, we see this as helping the behavioral health crisis because there'd be kind of more providers on the streets. It would also help the primary care crisis and the nursing shortage.
So just as a follow-up, are there any specific, say, referral pathways in place to connect residents to specialized care when needed?
Absolutely. Thank you for asking that. So we have currently, since we're just in Johnson Square so far, we have a connection with East Baltimore Medical Center where they save some slots for us of the people that we see. And then over time, we're planning on adding kind of a layer of telehealth along with it. But we in that way, we aim to be a really great connector to specialty care and care that's beyond the scope of the nurse or the community health worker.
Thank you. So I guess I'll take some of this off of you. We have a general question that came in and just want to know what advice, actually wants to know, are there ways that Baltimore City can be more involved in the growth of the program? And for that one, I'll just take this as from my city council lens. The first way that I see is just making sure that as many people know about the program as possible, to continue to collaborate with Johns Hopkins on doing things like this and making sure that I'm pushing out, as well as my colleagues are pushing out this information to the community. The next way is to figure out how can we work with our leading institutions who are collaborating on this. So we know it's not just Hopkins, it's the University of Maryland, it's Morgan State University, it's Coppin State University, but to make sure that we're helping and collaborating to see what is needed to expand in collaboration, this pilot program, a lot of times it's funding that may be needed, but where within city government can we find those funds to help out? Because as the chair of the Health, Environment, Technology Committee, health disparities, especially in our marginalized, our underserved communities, we need to make sure that we are sending those dollars there. So for me, it is engagement, making sure that we know, pushing out the information, and also working as hard as we can to make sure that our city budget is going to the things that will have the most impact.
I
So that's
love
just how
that
I would take it
answer.
from.
I would also add, although maybe this is too forward, that Baltimore is the great gem and jewel of the state. And the
Yeah.
state has a lot of power in whether this continues and grows. And the extent to which Baltimore City feels like the leaders of Baltimore City could talk to the state about how to grow it as well, I think would be another part of the answer if it were up to me.
No, and it's great. Yeah, we need to always partner with our state reps as well as our federal reps as
Yeah.
well, on this. Thanks so much for your question. Our next question is going to be, what has been the impact on the nurses involved in the program? How is this program touching our nurses who are involved?
Well, that's a great question. So I would say a few things, and I don't know if any of them are on, it could unmute, but I think it's super rewarding work to people because the nature of the work feels like you're really doing good work where people are, you're meeting people where they are, and there's not a time limit on the visit, and you're developing trust and helping solve situations. I think it's also been, in the couple months ago, there was a collaboration between the Baltimore Banner and the New York Times about the amount of opioid use disorder in Baltimore. And I don't know if people missed this or not, but we have double the rate of opioid overdoses for other cities of our size. And so I think that there's been a lot of good in how the nurses feel, and also it's been hard to take in the amount of overdoses and near overdoses that there are in Baltimore. And so I think it's just people use that. We all use that to recommit and re-inspire ourselves to what can we do for harm reduction? What can we do for treatment? And if you think about it, if you imagine if all of Baltimore and Maryland were blanketed with the nurses and community health workers, and everyone was wherever they were on the spectrum of substance use, if they don't use, all the way to if they use regularly and dangerously. If someone asked them about what was going on and was able to refer them, unless they had no use, and had Narcan and fentanyl testing strips, you can imagine if there's just like so many nurses and community health workers with those skills all over, you can imagine we'd have a lot fewer overdoses.
We definitely would. I always like to mention that we lose 3 times as many folks. Recently, it's been upwards of over 1,000 for the last few years as we do compared to what's usually talked about, which is the crime rate, our murder rate. So 3 times as many folks are dying yearly, as opposed to, say, our murder rate when we talk about population decreases and population decline, and talk about families. These are kids. These are folks who are never going to have children, lifelong Baltimoreans like myself and like others who are on this call who we're losing generations. I do want to go into the overdose crisis, substance use area just with a quick question. Can you talk about the specific outreach efforts or services within the neighborhood nursing program that's focused on those most at risk for opioid overdose within the pilot communities?
Sure. So we right away partnered with Behavioral Health Systems Baltimore. And so they come with us, the neighborhood nursing team in Johnson Square, and they provide Narcan and mental health referrals and menstrual hygiene kits and wound care kits and drug testing strips. And so we are working closely with them on how to address this. as well as, it's sort of helped us recommit within our nursing education to be sure that all the nurses we train are excellent at being able to provide all those services as well.
We're getting some amazing questions from the chat. I want to make sure I get back there from, I believe it's Leah, has a great question. Is there a role for school-based nurses in a program like this? They're some of our best advocates for kids.
I so agree. And I thank you. It's almost like we planted that question because 2 years ago, the city schools came to us and said, could you help us with the school nursing shortage? Because we all remember the schools were closed. And then when they reopened, the nurses weren't there because they had been, repurposed for other things. And we said, yes. And so Morgan State and Coppin State and Johns Hopkins have all committed to providing five schools with nurses. So between us, it's 15 schools. We've been doing that for about a year. It's going really well. And at first people said, oh, you'll never be able to hire them. You can't hire people for school nursing. Well, it turns out if you pay them the same amount they would if they worked anywhere else, you can. And so the school nurses love it. The question I know was, how does this connect to neighborhood nursing? And when we were first talking with the school system, I said, oh, in neighborhood nursing, it'll be so great. And there can be hubs and the schools can have the grandparents and the babies. And the school system said, hold on, just can we have school nurses for now? Can we just, and so I think it was Lee who said, is there a role? Yes, absolutely. I think these programs will come together over time because schools are certainly trustworthy places that are used to having nurses and used to this. But I think to be able to see the younger siblings and the babies and the grandparents and the parents at the school will take a little bit of a mind shift just from an infrastructure point of view. But absolutely, that's in our plans.
Great. Nursing students, are nursing students involved in any way in the neighborhood nursing program? And that's coming from Phyllis.
Great. Thank you, Phyllis. So yes, so I'll say yes and no. So at Johns Hopkins, the alumni who I talked to who graduated in the late 60s and 70s had a 3-month-long course where they were kind of responsible for blocks. And so when I talk to them about neighborhood nursing, they say, that was what I did in nursing school. And they're so excited and thrilled. And oftentimes it was their favorite thing that they did. The difference, though, is that they were students and the family would only have them for 3 months. And then the next student they'd have to tell their story to all over again or whatever was going on. And in our vision, we want to be so trustworthy and longitudinal over time. We want a teenager to have known a neighborhood nurse almost their whole life, if possible. And so students are involved in terms of learning and learning about the model. We don't want nursing students to be the primary neighborhood nurses because we don't feel it's really fair to the community members. So it's kind of a balance.
Okay. We have a ton of questions that are coming in. Everyone keep them coming. Tara wants to know, does the neighborhood nursing program see or address health issues affecting persons experiencing homelessness?
Absolutely. So in the very beginning, I mentioned a 5-year-old who was recently homeless or houseless, who was behind on her vaccinations and other care. And so she couldn't go to kindergarten. And so the community health worker resolved that and she got back in school. So I think, if you think about people who don't have homes, there's people who, are evicted or have a house fire, something that's kind of a temporary situation. And there's people who that could be temporary and then it could turn into long-term if you don't have these kinds of supports. And then there's people who've been on the streets for years and years. And we are intervening at all of those levels. We also are working very closely with Healthcare for the Homeless, which is, a fantastic organization that is on the streets and develops housing for people and has a really great clinic by the Falls Way. And so part of it is working with them and part of it is doing what we can where we are.
Talk to us about the long-term goals, or dreams that you have for the neighborhood nursing program. How do you envision this program evolving over time?
Well, thank you for letting me get to my vision board. I mean, in my mind, this would be standard operating procedures for the whole country. And that if you look 5, 10 years from now, every place has learned from Baltimore and Maryland and said, oh, this makes so much sense. And I can see how you paid for it with the decreased emergency hospitalizations and the decreased surgeries and the fewer kidney transplants and cancer that's caught sooner and children being ready for school because they've been vaccinated and they're not missing school. And that our leaders come together and say, of course, we need to do this. And we can all be proud and say, yeah, we remember we were talking about that in 2024. So that is my dream. I think it will unlikely to be a national program. It's not going to be like Medicare. I think it will differ state by state and city by city to some extent. But the idea of seeing people geographically and where they are, whether it's home or work or laundromats or libraries, I think is a really powerful one that will grow.
I love the vision.
Thank you.
And listen, I know there are so many leaders across the city, the state, this country who are rooting, but you have a leader right here for, for the neighborhood nursing program. I want to talk about maternal health.
Great.
How does the program specifically address maternal health within the pilot area, particularly for women of color, Black women, who often face higher rates of maternal mortality?
Yes. So as you underscored, Black women are much more likely to have hard birth outcomes and to die. And also it's not economic necessarily. I think probably of that a graduate of Johns Hopkins School of Public Health, but a PhD died after giving birth to a baby. And so it's a really intensely serious health problem that's entirely preventable, almost entirely preventable. It's inexcusable that in this country at this time, people die from childbirth. And not just die, but, have high blood pressure or diabetes. So we're doing multiple things. One of the people, Ashley Gresh, who has been busy developing this program, is a midwife, and she's a pioneer in group visits. So, I think people used to think, well, one-on-one visits are the best possible visits. But it turns out that group visits, both prenatally and postnatally, are often more effective because it makes people have a support system as well. And there's so much kind of education and learning as you're moving forward. It helps to have it be together. And Ashley Gresh, who I mentioned, is also a pioneer in pushing for the postnatal period to be a year instead of 6 weeks. And there's more and more evidence that if you treat that period as being a potentially tricky period for 12 months, that you're much more likely to decrease hospitalizations and high blood pressure and diabetes. So I think that being able to be in the be where people are and be able to support people along that journey will impact maternal morbidity and mortality. And importantly, if you look at some of the, like Serena Williams or some of the people who are more famous who faced terrible, or very difficult birth outcomes later, a lot of times it was because they weren't believed or they weren't listened to or they weren't trusted or they were a bad historian in somebody's mind. And if you go into those vulnerable periods with someone who's got your back, who knows you across time, who's been your nurse over time, I think we're much less likely to have those situations that a nurse could kind of translate or say, use these magic words, say you think it's a blood clot, or that people will have someone who's got their back in terms of maternal health.
Thank you for that. It takes a lot to advocate for yourself, especially in a medical setting as a patient. And it's very important to me that we are speaking about these issues, especially with the communities that this program is serving and will serve within the future. We have went through a serious pandemic. I often tell I have 9 nieces and nephews, I often tell them, you live through a portion of history. You lived through a portion of history. How has the COVID-19 pandemic influenced the design and implementation of the program?
Well, so we didn't think of it until after COVID. So we started it started writing about it, thinking about it in the fall of 22. And then last fall is when we started like the formal listening sessions and talking to communities. And that doesn't mean, we are still in the midst of COVID. And I think part of it, as I mentioned, I think there's such a more anxiety and depression than there was. We're more polarized than we were. There's less trust than there was. So I would say that COVID has really affected how we need to move forward as a society in terms of health. But the actual literal, the emergency part of the pandemic wasn't part of neighborhood nursing. I do think, though, that for the next pandemic, imagine how many more people would trust vaccinations and trust the public health guidelines if they were coming from a community health worker and a nurse who they already knew, who was already in their neighborhood.
Just as a quick follow-up to that, what lessons from COVID-19 are being applied to health outcomes in low-income neighborhoods through this program?
I think we've learned a lot about the need for trust and trustworthy messengers, and for skills like motivational interviewing, where we really listen to what matters to people, and then work our messages and actions around that. And I think that really comes together nicely with how neighborhood nursing works.
Thank you. We're going to go into just one last question, and then we are going to close out. And it's a simple question. Are there plans for other Hopkins connected hospitals outside of Baltimore to start programs soon?
So, so this program isn't from Johns Hopkins Hospital, it's from the School of Nursing, just to make that distinction. I think that it'd be great if other parts of Hopkins start doing neighborhood nursing as well. One of our thoughts is that neighborhood nursing teams could be connected or paid for by some of the hospitals. So for example, if Bayview or Sibley, if they wanted to make sure the neighborhoods around them were healthier as part of their mission, but also keeping the emergency room less crowded, they could contract with or make neighborhood nursing teams. So that's part of the vision.
Thank you so much for that answer. That is our last question for today, and we are approaching the end of the session. I want to thank you so much.
Thank you.
And your amazing nurses within your program. We appreciate you and appreciate the work that you all are doing within the pilot communities. Thank you for taking your time to also share information about this incredible program, and we are grateful to have this resource in Baltimore and just wish you continued growth and success. I also want to thank everyone who tuned in to listen to the conversation today. For more information about the Showcase series, please email the Johns Hopkins Government, Community, and Economic Partnerships team at gce@jhu.edu. Again, gce@jhu.edu. We're going to throw that in the chat for you as well. And for more information and to register for the next Dean's Notebook featuring Krieger School Dean Christopher Chilenza on October the 10th, visit hopkinsathome.jhu.edu. Thank you again, and I hope everyone has a wonderful afternoon.
Thank you. Thank you so much.